welcome back to another episode of MedSynapse podcast series. I'm your host, Hetwisha, and today we are focusing on a critical topic that every physician should know, which is glomerular diseases in 2025. The updates every physician should know. The landscape of glomerular diseases is changing fast, with new diagnostic tools, treatments, and strategies emerging every day. Joining us is Dr. Naveen Kumar Mattewada, a dedicated nephrologist and internal medicine specialist trained at JIPMER Puducherry. He brings extensive expertise in interventional nephrology, glomerular diseases, AKI, complex transplant cases, and is passionate about advancing the field through research and mentoring the next generation of nephrologists. So, Dr. Naveen, it is such a pleasure to have you with us and welcome to the show.
Thank you for your kind introduction and thank you for having me on this show.
Thank you, and likewise, I'm very excited to have this discussion with you, Doctor. So, to begin with, how has the landscape of glomerular diseases evolved in recent years? Leading up to today, like until 2025.
If you look at the glomerular diseases, like the initial part, it started when kidney biopsy procedure was started. Subsequently, there was introduction of immunofluorescence, which has helped us classify the diseases based on the light microscopy and immunofluorescence. And then we got electron microscopy, which has helped us identify some podocytopathies. But if you look at the recent developments, the trend has been towards the it is being shifted from histological diagnosis, that is classifying the glomerular diseases based on histopathological findings has been the initial approach, but now it is being immunological basis, and rather the pathophysiology is being considered, and that is being considered for classification of diseases. And if you look at C3 glomerulonephritis and things like thrombotic microangiopathy, IgA nephropathy, the focus has shifted mainly from the histopathological process to the pathophysiological basis of the disease. And there has been some recent advancements in the genetic causes of kidney diseases, and mainly glomerular diseases. And there is increasing awareness also that at least 10 to 15% of the ESRD cases are contributed by glomerulonephritis. And this is one particular area of nephrology where timely diagnosis and treatment might prevent the progression to ESKD. And of late, there is increasing awareness not only among nephrologists but also physicians, and thanks to some initiatives like GlomCon and International Society of Glomerular Diseases, which are contributing to this.
I think that is fascinating, and I think it is so clear that both the understanding and approach are becoming more precise. So it's really interesting to know, Doctor. So now, Doctor, let's talk about diagnostic. How is the role of kidney biopsies, biomarkers or non-invasive tests has changed in 2025? And are there any emerging tools that are improving early detection?
So if you look at the diagnosis of glomerular diseases, kidney biopsy has been, and if you ask me, it is still the gold standard for diagnosis of glomerulonephritis. But of late, like you said, there are definitely newer biomarkers. If you look at membranous nephropathy, there is anti-PLA2 or antibody levels, which are which can be used in certain special situations. There are a certain criteria where it can be used to replace a kidney biopsy. So if those criteria are satisfied and patient turns up to be PLA2 or antibody positive, we can forego the biopsy and directly treat the patient as membranous nephropathy. And of late, there are anti-nephrin antibodies that are coming up. So These antinephrin antibodies are seen in podocytopathies, FSGS, and minimal change disease, where it has some diagnostic and prognostic value, but it is still in the development process and it is not into clinical practice as of now. And along with that, there are certain systemic diseases and vasculitis where there are biomarkers which help to, they are more supplementary to the kidney biopsy than replacing the kidney biopsy. So with regard to diagnostic tests, I still say kidney biopsy is the gold standard, but probably in near future there might be more biomarkers specific to each and every subset of glomerulonephritis, and there might come a day where we can diagnose without a kidney biopsy.
Yeah, I think those, it's exciting to hear about those, and I think less invasive diagnosis also should be there. So it's really interesting, and it would obviously be in upcoming years also.
Yeah.
So now, Dr., could you highlight any treatment options or approaches for major glomerular diseases like IgA nephropathy, FSGS, or membranous nephropathy that have gained traction recently?
If we look at the glomerular diseases, there is some renewed interest even with regard to translational research and even clinical research. If we look at some diseases like IgA nephropathy, there has been some newer formulations of drugs and some newer classes of drugs. So there is targeted release budesonide, which is being marketed as Tarpeo, but in India it is being marketed as Iganef, which is like a targeted release budesonide, which is delivered at the Peyer's patches in the small intestine. So thereby what it does is it targets the Peyer's patches, which is present in the distal ileum, and this is the part where the production of the pathogenic galactose deficient IgA1 happens. So because it is a targeted release, these side effects associated with the steroid usage are lesser compared to using oral steroids. So this has been shown in clinical trials to be effective. And with regard to other drugs, there is sparsentan. Sparsentan is an endothelin 1 and angiotensin 2 receptor antagonist. It targets dual pathway. So this has been shown in clinical trials to reduce the proteinuria and slow the rate of decrease of GFR. So this has also been approved in September 2024. And coming to the other drug in IgA nephropathy, it is iptacopan. This is a complement factor B inhibitor. So IgA nephropathy is a complement-mediated disease, and the APLAS study has shown that there is about 40% reduction in proteinuria with iptacopan, and it has also received FDA approval in 2024. So these are some of the newer drugs in IgA nephropathy. And coming to FSGS, again sparsentan, which is a dual endothelin receptor 1, endothelin 1 and angiotensin 2 receptor blocker. It has been studied in duplex study, and this trial did not meet the interim endpoint, but there was some indication that sparsentan has led to rapid decrease in proteinuria. So this might be one drug which we have to keep lookout for in FSGS. And there are some other drugs like DMX-200, which is a chemokine receptor 2 pathway blocker, which is being studied in FSGS. And then coming to membranous nephropathy, rituximab, there are many studies which have looked into the role of rituximab in membranous nephropathy, like the Mentor trial. Of late, there is some interest in obinutuzumab, which is also a anti-CD20 monoclonal antibody, which is next generation compared to rituximab, and it is designed to be more potent B-cell depletion, which happens through ADCC, that is antibody-dependent cellular cytotoxicity. So, what it has been shown in many case reports and case series is that obinutuzumab can be used in patients with refractory membranous nephropathy, and in cases where rituximab has failed to induce remission. And there are some trials, the Reboot trial, which is looking into role of belimumab in combination with the rituximab in membranous nephropathy. And if you look at the trials in SLE also, like of late, belimumab is being used in SLE, and it is even recommended in the latest KDIGO guidelines as an adjunct therapy to the standard of care in severe cases. And there are newer CNIs like the oclosporin, which are being recommended in SLE. And coming to ANCA vasculitis, it is rituximab has been recommended for quite some time now, and there is robust evidence showing that rituximab is useful. These are some of the newer treatment options which are still evolving, and probably more will come in future. And there is one avacopan which has been shown to reduce the steroid requirement in ANCA vasculitis, and it has shown to have better outcomes at the end of 24 months of follow-up. So these are some of the newer drugs.
Yes, I think that was such a valuable insight that you shared about the drugs and the potential upcoming drugs as well. So, Doctor, now have strategies for preventing progression to chronic kidney disease or end-stage renal disease shifted in glomerular conditions?
When we look at glomerular diseases, the traditional approach has been mainly focusing on the immunosuppressive treatment, which is targeting the ongoing inflammation. But of late, there is some shift in focus, and if you look at glomerular diseases, as the time evolves, there is damage accrual, and there is some amount of interstitial fibrosis, tubular atrophy, and glomerular sclerosis, which is happening, and this is contributing to progression of CKD. So, in addition to focusing on the immunosuppressive regimen, the recent approach has been to focus on the conservative management of CKD as well. That is, we try to reduce the proteinuria through antiproteinuric drugs, that is RAS blockers, either ACE inhibitors, angiotensin receptor blockers, and along with that, the newer classes of drugs like SGLT2 inhibitors, the gliflozins, either dapagliflozin, empagliflozin. Although there are no randomized controlled trials looking at their efficacy in glomerular diseases per se, most of the trials have included good number of cases with glomerular diseases like IgA nephropathy. So in these trials, the subgroup analysis has shown that they are effective in reducing the proteinuria, and they are effective in reducing the loss of GFR. So in glomerular diseases, along with the immunosuppression, we'll have to focus on reducing the proteinuria through the use of RAS blockers, SGLT2 inhibitors, and managing the dyslipidemia with the use of statins. And we'll have to focus mainly on blood pressure control and glycemic control. These are small things which help the patient in like reducing the progression to ESRD and thereby preventing or delaying the dialysis.
Yeah, I think that is a crucial focus, and I think slowing progression is where we can truly change lives also, I think.
Yeah.
Now, Doctor, finally, what advice would you give to physicians when it comes to patient counseling, especially regarding, lifestyle or adjunctive measures that have strong evidence today?
If you look at the lifestyle advisors, mainly most of the patients are confused with regard to what to take and what not to take in the diet. The most important thing is sodium restriction. So sodium restriction, that is less than 5 grams of salt per day, is recommended, and it helps in one thing is it reduces the systemic hypertension, and along with that it reduces fluid retention, and there is some evidence that it reduces the proteinuria also. And then coming to protein intake, there is some confusion, like there is a thought process where, because glomerular diseases are associated with protein loss in the urine, there is some confusion. Some of the clinicians recommend high protein diet, but what is recommended is a low protein diet, that is 0.8 grams per kg per day of the ideal body weight is the protein requirement. This reduces the filtration burden on the kidneys, and thereby it reduces the glomerular hypertension and prolongs the lifespan of the kidney. And along with that, patient should include high fiber diet and a higher amount of plant-based diet. There is increasing evidence showing that plant-based proteins are better than animal-based proteins in preserving kidney function. So better to use plant-based proteins along with high fiber content. And coming to physical activity and weight management, moderate intensity exercise of about 150 minutes per week is recommended. And other lifestyle factors like smoking, complete cessation of smoking is recommended, because smoking has been shown to increase the progression to ESRD. And these lifestyle changes are not only recommended from the kidney perspective, but they are also helpful in reducing the cardiovascular risk and improving the overall health of the individual. So balanced diet and balanced lifestyle, that is what is recommended, and it goes a long way, not only for preserving kidney health, but preserving cardiovascular and overall health and well-being of the individuals.
Yeah, I think that's a great takeaway for all of us, and especially the physicians also, Doctor. So thank you so much for sharing that. And as we wrap up today's session, thank you so much for sharing your expertise and practical insights on such a crucial topic. And I think this conversation will surely help physicians stay updated and improve patient care. So thank you so much, Doctor.
Thank you.
And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, take care and stay safe.